office has got a number of staff, and I'm always happy to come to Haiti. I helped birth this hospital right after the earthquake in 2010, and today it is the only operating trauma hospital in Port-au-Prince, a city of some 4 million people. We are a 50-bed hospital and see anywhere from 400 to 500 people in various outpatient clinics a day. So it's a very busy place, a lot going on. We're right in the middle of a very difficult part of Port-au-Prince, so I'm happy to be here, and hopefully the electricity will hold up, as it seems to shut off 4 or 5 times a day. So hopefully we'll get through this. So Sergio, should I just continue on?
Please, go ahead.
Okay. All right, great. You know, guys, I travel around the country speaking on national health reform quite extensively. And for a while I started talking about what are the impacts and responses for providers and the design and construction community. And I was getting a lot of questions about, well, how exactly did we get here? And it's very helpful to understand the business problem within healthcare so that you can understand what health reform means business-wise and how that's changing the delivery of care, and then how does that new delivery of care impact both providers and the design and construction community. So I want to start right here at the current status of health reform. We got a number of slides. I'm not going to read all of these. Y'all can read it in a fraction of a second than I can, but I want to point your eyes to the last bullet on this slide. Risk is shifting from the payers to the providers. And that's what health reform is all about. We're going to speak a lot about risk, but let me just share this with you. Presently, the providers, those are the insurance companies like Blue Cross, United, Aetna, and so on and so forth. Our reimbursement model, and you've all heard this, it's a fee-for-service model, and that is rapidly changing. And because of health reform, the payers are now by law required to perform something called guaranteed issue, which means that they cannot turn anybody down, and which means they're going to take on a larger risk. Because what are insurance companies? They're in the business of risk, and they don't like taking on risk. That's why they turn people down for pre-existing conditions. The other thing is there's some 30 to 40 million presently uninsured that are going to be on the rolls January 1st next year. Well, what is the response for the payers? And the payers is this thing called risk shift, which means the reimbursement model is going to move away from fee to service to a term, and there's several terms, but they mean the same thing. The value-based purchasing, the capitation, those types of reimbursement models put the risk for the cost and the care onto the provider. And so simply just because of that change in reimbursement changes the way that providers are going to be delivering care, and that has a profound effect on the facilities. So let's get into how did we get here. So let's just look at a number of slides. There are 3 metrics worldwide between developed nations where we're able to compare the health of one nation to another across commonly measured metrics, and one of them is life expectancy. And of the developed nations, you can see pretty quickly that the U.S. is one of the least healthiest in life expectancy. That's pretty amazing, right? So let's look at the next metric, infant mortality. The U.S. has the largest infant mortality of other developed nations. It's unbelievable. And the third metric, I don't believe I have a slide for the third metric, but it's this thing called quality adjusted life years after age 60. And what that means is how well or how healthy are you once you achieve age 60 till the end of your life. The U.S. again scores one of the lowest. So that's pretty amazing. And I'll show you some slides in a minute when you look at the cost. But we spend the most and we're the least healthiest. That's a big problem. So let's drill down on that and look at some of the data. So Sergio, I'm moving to slide 6.
We're there now.
Okay, so take a look at slide 6. Color graphic, you can see where the U.S. life expectancy is the lowest in the lighter colored areas. Well, interestingly enough, if you overlap this graphic with some of the chronic diseases like obesity, you find out that the largest percentage or the largest demographic of obese people and coronary heart disease is in the same color scheme as in this graph, in the lighter areas. So that's one thing that we're terming population health management. So providers in one particular area may provide programs more situated to targeting obesity and heart disease. So move on to slide 7, Sergio.
Okay.
And again, I'm not able to control the presentation, everybody, because of connectivity issues down here. So take a look at this slide. We're the only wealthy industrialized nation that doesn't have a universal health care. And in 2010, without insurance was 16.3%, almost 50 million people. Interestingly enough, last September, the General Accounting Office released a little factoid that never made it to the media, that the the total number of uninsured people was actually 53 million. Interestingly enough, the number that's tossed about amongst speakers in the media is some 32 million. So wide discrepancy. And another very interesting thought, when health reform was first being promulgated back 5 years ago, those of us on the provider side, and I include myself on that, having spent most of my career on the provider side, thought, you know, the purported savings out of insuring or covering the cost of the uninsured is not going to offset the rising cost of the care. And we didn't think it would work at 30 million and clearly not at 50 million. So, but that's yet to be seen, and there's a lot moving on. Interestingly enough, let me talk about that. The term Obamacare, health reform, Accountable Care Act, all the different terms applied to it. And I get this question a lot. So what do you think about Obamacare? And here's my answer. You know, I really don't care whose name is on it. It could be Bill Smith or John Doe health care reform. It doesn't really matter. The fact is, health care as an industry absolutely has to reform. And the reason is because Medicare, Medicaid program is quickly going broke. In fact, I got a slide on that coming up. So let's move to slide 8, Sergio.
Okay.
All right, so you can see our budget this year puts health care at 24% of the total federal budget. Not surprisingly, health care has been the largest slice of the U.S. federal spending pie for many years. And look at that, nearly 1/4 of our entire federal budget is spent on health care. And what did we learn about health care just a few moments ago? We're the least healthiest nation of industrialized countries. That's unbelievable. Let's move to slide 9, Sergio.
Okay.
Here's some more specific numbers. You can see the order of magnitude. That's pretty amazing. I mean, that's a serious amount of money, right? That's per capita. That's for every man, woman, and child in the country. We're spending $7,500. Now, that was in 2008. And that number now is over $8,000. I know this is an old slide, but pretty startling, right? It's just amazing. So let's move to slide 10. Healthcare spending. You can see right here that with health reform, we're going to go broke in 2016. We already know that. And without health reform, it's with health reform, it's 2024. Without health reform, it's 2016. So clearly you can see that health care had to reform. Unfortunately, on the provider side, we knew this for many years ago, even as far back as the Clinton administration. We knew health care had to reform, but we didn't get our act together. We didn't clean up our shop, and now this is what we've got. Is it perfect? No. But it does get us off of square one and moving us forward. Will the Accountable Care Act, Obamacare, will it continue to evolve and play out? Absolutely. And I'm going to show you some slides how federal legislative efforts since 1964 have continued to evolve all the way up until this day, and health reform is no different. So let's take a look at slide number 7. Okay, quick little summary from where we're at. The U.S. spends the most and is one of the least healthiest developed nations in the world. That's pretty profound, but unfortunately that's where we are, and that's how we got here. So let's take a look at slide 12. This is a quick little history lesson, and many of y'all, if not everybody, is probably familiar with the majority of these bullets here. Baby boomers came on at the close of World War II. Hill-Burton Act came out in 1946. Just a quick moment on that. That Hill-Burton were two senators that put together the plan that said communities and hospital organizations could receive federal funding to build hospitals. There weren't enough hospitals right after the close of World War II. Obviously, you've all heard the baby boomer demographic as a group, as the largest single group moving through our society. So many hospitals were built, and the caveat that came with the federal funding at that time was that they had to take care of people that were unable to pay for their own care, and that was the birth of the indigent care problem in our country. Medicare and Medicaid came on in 1964 to attempt to stabilize the amount of fees being paid. In fact, back in those days, the fee was reverse incentive. In fact, the more you spent on care or the more you spent building your facilities, you were incrementally paid a higher amount. So it was reverse incentive to save money. Obviously, the more you spent, the more you made. Geometrically, it was unbelievable. So what did they do? Tried to slow things down again with certificate of need. Today, there's only 34 states that still have some form of certificate of need, or more commonly CON, on the books. It's a federal law that's administered through each individual state. Certificate of need attempted to slow the amount of construction by providers having to win a grant to be able to do that. I don't need to get into that. You've heard of fee-for-service. You've heard of DRGs. All of that led up to EMTALA. EMTALA is the law that says any person, regardless of ability to pay, can be treated in any emergency room receiving federal funds at any time, day or night, and they have to be stabilized before they can be transferred to a more appropriate facility. Back in the 80s and 90s, we tried partnering and working with physicians. But unfortunately, that move back in those days was really an effort to garner more patients, and by attracting the physicians, we could persuade them to admit more of their patients to one hospital more than the other. The term used back in those days, still around today, was a term called splitters, and splitters referred to private physicians that had allegiance to more than one hospital, and they would split patients from one hospital to the next, and so on and so forth, and actually use that against hospitals. When they didn't get their way, they would negotiate with the hospital and say, well, I'm going to stop admitting at this hospital and take them over to that hospital, and that's a lot of what went on. So Stark Law, False Claims Act, by the way, Stark Law is managed through the False Claim Act. So if you're indicted on Stark Law, they bring you up on False Claims Act, which is very serious. All of that led up to the Balanced Budget Act in '97, huge reduction in reimbursement fees, and now here we are at Health Reform 2011. Interestingly enough, every one of those bullet points on this slide has continued to be revised and amended since their inception, and Health Reform, I am absolutely certain, will be no different. So slide 13. So what's next? All right, this is where this starts to get interesting. There's three game changers that's going on. There's a change in reimbursement, the physician alignment, and the move from sickness to wellness. And we're going to talk about each of these in a little bit of detail. So Sergio, if you'd move to slide 15, please. So let's look at the payment system. Presently, the payers, as you can see, are moving downstream along risk shift to the providers. And so presently we're at fee-for-service. There are some bundled payment systems, and there is some capitation or value-based purchasing going on around the country, and that's going to continue to move forward until we get to fully capitated or fully based value purchasing systems. What will that look like 3, 4, 5 years from now? Hard to say, but directionally it'll be somewhere along the line, perhaps as transparent as, well, this is a little bit out there, but it kind of points you where we're headed. It'll be like buying cars. Not that you would buy one car over the other, but as far as being able to determine the prices for health care, you'll be able to go to hospital's website and say, okay, I'm going to have a total knee replaced. and I'm a 56-year-old male, and it's going to cost X thousands of dollars, and that's the price. You'll actually be able to see what the prices are. Presently, right now, I challenge any one of y'all to try and figure out what it would cost at the end of the day to have your knee replaced. So let's move on to slide 16. Physician alignment, hugely powerful, hugely powerful. Physicians, let me paint the picture for you. 4 years ago, 64% of all physicians in the country were in private practice, defined as either in solo or in group practices. The balance of the physicians were in non-patient care, like research, education, insurance, things of that nature. Today, only 34% of all physicians are in private practice. You say, well, what happened? Physicians are in droves joining hospital organizations through a variety of employment models, such as direct employment, hospital-managed companies, foundations, especially out in California. There's a variety of different employment models, and they're moving into this. And why is that? Let me paint a picture for you. When physicians and hospitals are properly aligned along the value chain or the care delivery of a particular patient or an acuity, the hospital and the physician can both realize together tremendous cost savings and better care outcomes. And let me just give you one example so you can understand it. Most hospitals will have an orthopedic group or two that are performing most of their orthopedic surgeries. So this is just one example. And amongst all of those orthopedic physicians, they may be ordering knee replacements from 3 or 4 different manufacturing companies. And so over the course of a year, a couple thousand knees might be purchased by the hospital. But because they're buying many knees from many different manufacturers, the price that they pay is a pretty high price. Whereas if all the physicians can agree on a few types of knees from a couple of manufacturers, then because of what? Value purchasing or bulk purchasing, the price per knee drops considerably. Now that's just one item, and you can imagine the numbers of items in just material costs and medical supply costs across a year used in an acute care hospital. Thousands and thousands of items. So just in supply costs, the reductions are tremendous. Not to also include onto that better care, less same issue readmission, things of that nature. So let's move on. Let's start moving into more design and construction. So take a look at slide number 17. This is one of the most powerful slides I've seen around in a long time. This is integrated construct, and it wasn't that long ago where talking about facilities was literally bricks and mortar with some communication between operations, and that's how it went. You will all recall where IT closets were just that, closets. Tiny little things, not much bigger than a broom closet with some equipment hanging on a piece of plywood on the back wall. Today, as you know, EMR, HIT, physician health records, everything is completely integrated throughout the hospital from the day the patient walks in the door at admission, their medical record, their discharge orders, and finance collections. Everything is tied back together. And so when you begin to look at design and construction as an integrated model like this, it starts to set up how the design community needs to begin to think differently than just bricks and mortar. Let me help you understand this. You will recall where not too many years ago, just the IT IT and telecommunications might have been 3, 4, 5% of the construction cost of a new facility. Today, that number is approaching over 20, 30, 40%. We are anticipating in the not too distant future where the total IT complement of a new greenfield facility could be equal to or more than the actual bricks and mortar cost. And that's because the IT component is so integral with operations today and in the future that it's literally going to be controlling the hospital through every aspect, including major pieces of diagnostic, lab, pharmacy, everything right down to the patient actually having care delivered in their home, and I'm going to show you what that means graphically here in a few minutes. So, Sergio, these next set of slides, I just want to show you how far health applications has come. So these next number of slides, we're going to move through them pretty quickly. But Sergio, if you just switch to slide number 18, please.
Okay.
Okay, slide number 18. In fact, for those of y'all that have iPhones right now, this will be probably very interesting to you. There are applications available on the iPhone right now, today, that you can have your health measured, monitored, and results transmitted to your care provider. So let's just click through these. This is one right now. This is a glucose meter, diabetes. On your iPhone, results can be sent to your care team. Pretty amazing stuff. Number 19, take a quick look at that. Cardiac monitor, right on your iPhone. That's amazing stuff. The next slide, number 20, Vitals Health Tracker. All of these applications can monitor the individual person with the health results sent to either yourself, of course, or to your care delivery team. And I want to keep using that term, care delivery team, because we're going to talk about that, as that is a component of, remember I mentioned we're moving from sickness to wellness. We're going to get to that in just a minute. Take a look at slide number 21. Skin cancer test. Pretty amazing. Right there over your iPhone. Send the results to your dermatologist, plastic surgeon. Slide number 23. This is something that we're actually using in Haiti right now. It's a mobile or portable retina scanner attached to your iPhone. Phenomenal, right? So an ophthalmologist can travel to Haiti or other third world countries, already have in their bag the appropriate tools to fix an individual's eye without having to first come do the exam, go back to the States, get the supplies, and come back weeks or months later. It's just phenomenal. Take a look at this. Smart medical home, a way where patients discharged can take better care of themselves. In fact, one of the single largest reasons why patients are readmitted for same disease is failure to maintain their health when they return home. They forget to take their meds, they don't take their meds, they take too many, they do this, they don't do that. But a smart medical home can help us bridge that gap. We're going to talk more about that in a little bit. And then look at slide 24 quickly, Genome Wowzer. Let me give you an example. You've probably all taken a 10-day course of antibiotics sometime in your life. Well, imagine the pharmaceutical companies formulating a medicine prepared with your specific DNA. One pill, cured. Amazing, right? Talk about increase in efficacy. Unbelievable. This is what's coming. Take a look at slide 25. Right there, more heart applications can be sent to your care team. All right, so slide number 26. So what's the response? I know we're flying through a lot of material here. We've got still pretty good ways to go. So what's the response for providers? So Sergio, please move to slide 27. Okay. Are we there?
Population management, yep.
Okay, very good. Very powerful slide. This is a graphic depiction of the response of what is the result of healthcare reform. So let me go through it. There's a lot of subtle things happening in this slide. Let me spend some time here. Obviously, you know, we're in fee-for-service and we're moving to capitation. But what does that mean for the delivery of care, and what does that mean for the facilities where the care is delivered? And that's where we're going to spend the rest of the presentation talking about. So let's just slow down and let's digest this. You're all working presently in big box hospitals, and that could be any hospital in America. For many years, we've had multi-specialty clinics and ambulatory surgery centers, as denoted by the next largest circle to the right. We've had that for a long time. We've called that outpatient because it was an outpatient surgery, or there were outpatients being performed in various practices. And I'll ask you this. If you had to go to a multi-specialty clinic, an ASC, or to a big box hospital, you are likely already experiencing some disease or some acuity at some level. You're already sick to some degree. Now, let's talk about the set of circles in the pink. physician offices, walk-ins, urgent care, some areas that we refer to them as freestanding ERs. There's quite a number of them in Texas. In fact, Texas is leading the way in freestanding ERs. There's a number of states that have them, and they're more or less being accepted, but with a struggle. We talked briefly about health information technology applications, home care, retail care. You can walk into many Walgreens and CVS's and see clinics set up. And in a lot of those cases, the actual exam is free because they know that you're going to purchase pharmaceuticals from them that covers the cost. So let's look at this and let's understand a couple of the subtleties. The pink set of circles is wellness. You're still pretty well if you're going to those types of facilities. So think of this. If you're the CEO of your hospital and you're receiving a capitated amount, let's talk about that for a second. So one of the insurance providers, or excuse me, payers, comes to you, Mr. CEO, and says, you know what, Sergio, within your primary service area, you've got 100,000 people that are signed up to our health plans, and I'm agreeing to pay to you, say, $8,000 per year per person on the plan. Now, in exchange for that lump sum payment, hang on a second. Hey, guys, I need some quiet, please. Very quiet. Sorry about that. So, where was I? So you're the CEO, and the insurance provider is going to give you $8,000 per person, every man, woman, and child in your plan. So you're thinking to yourself, wow, if nobody shows up at my hospital, I still get $8,000. So how do I make a lot of money? I don't want anybody in my hospital. I want an empty hospital. Now, clearly, we got to have enough patients to stay in business. But how do I manage the care if some people are going to come in for a runny nose and some people are going to come in for open heart surgery? Pretty big, right? So the way to have the fewer people in your hospital that runs your cost or your expense up is to keep them well and keep them out of the hospital. So you develop a network of care delivery, both facility and in the care side, to keep your patients well. Now that's wellness. How do I keep my patients well? And I'll share this with you. The cost of care delivered in the pink set of circles is a fraction of the cost for the same disease treated in the multi-specialty clinic or in the big box hospital. This is a profound slide that has huge facility impacts. Okay? So let's move to slide 28, Sergio. All right, so let's talk about on the provider side, and move right on to slide 29, if you would, and tell me when you're there.
We're there.
Okay. Strategies and tactics on the providers. You've all heard of plenty of these. However, it's the implementation and how it actually works. And service line centers of excellence is about delivering better care than your competitors. In fact, I can't say the word competitor enough. Every single hospital in America is competing with their neighbors, and depending on their primary market areas, could be very many neighbors, depending on what you do. So service line centers of excellence, you're going to have to compete for every single patient. You're going to have to fight for every single customer. And that means doing it better, doing it friendlier, doing it cheaper on the expense side with better outcomes. And that seems like, you know, pretty simple to do. It's very difficult to do, but that's where you're going to excel. The notion that every acute care hospital can do everything is completely out the window. That is absolutely not true. That has not been true probably forever. Most of the citizens of the United States don't understand that. But when you have one acuity or another, you need to do the research. This is just a little aside. You need to do the research and go to the best hospital that performs the service that you need done. Customer awareness and education, same exact thing we just talked about. Community access. What does access mean? Access means you got to be able to have some kind of insurance or ability to pay, and there also has to be the facility access. So let me explain it this way. I know that in California there are millions of more people soon to come onto the rolls, and I know absolutely there's presently today not enough clinic space or facility spaces to treat the massive influx that's expected. There needs to be many, many more facilities. So let's just talk about that for a second. You've probably all heard the term moral hazard. Moral hazard is when somebody or someone overuses something because they perceive that it has no value to them. So let me share that with you. Let's say you could all eat filet mignon for $1 at some well-known steakhouse. We'd probably all go there more often if we weren't so health conscious. But because we know that it costs you $100 to eat there, we don't eat there so often. Well, it's the same thing in any other thing. And when the presently uninsured now have insurance and they're paying a fraction of that cost for what it would have cost, they're going to overuse it because, A, they've never been treated other than coming into ERs, and they've certainly not been on any wellness type program. So they're going to, for a while, they're going to overuse the system, which is going to overwhelm our healthcare infrastructure today. Clearly, that's going to happen on the facility side. We cannot catch up quick enough before January 1st comes online. As you know, come October, the exchanges will be made public for the fees, and that's where we'll see some big adjustments made. Okay, hang on a second. Could you close the door, please, when you leave? Thank you. Okay, sorry about that. Okay, and the last 3 bullets, there's a reason why I made that all the same: service, service, service. I got to tell you guys, and I can say this because I've spent my career on the provider side, hospitals are not hospitable places. We need to take the page out of our hotel friends and our hospitality friends. We got to be more hospitable in our hotels because it's all going to be about winning customers. Think about all the big chain, big box corporate stores that you go to all across America. It's service, 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 service. And if you're not on your game every single day, customers have choice. And we're soon going to have choices, definitely in healthcare. It's a big deal. Okay, so let's move on to slide 30, please.
Got it.
Okay, so provider impacts, you know, you've heard lots of different things, but when you break it down, what are the types of care delivery models? And there's really only 5 of them. There's the traditional model that we're in. There's the risk-based that we talked about. There's the disruptors like the CVS coming on to the market, treating patients that otherwise used to show up in your ER or in your clinic. There's networked, where various hospitals and providers join together. That's kind of been around, but it's becoming much more formalized now. And then there's partners, and let me share with you what partners might mean. Suppose, for example, that you learned that within your primary area you had an extremely high demographic or population base of diabetes-type patients, and your care cost, your per-patient care cost was high. Well, you can organically work on a better diabetes program, lower your cost, deliver higher quality care, so on and so forth, build the facilities. You can do all that. Or you can do what? You can purchase that service for your system and exchange the fee to do that. So we can either, you know, it's the old make or buy decision. Do we bring it in-house internally and struggle through that, or we just contract with somebody that's all they do is diabetes management, right, or dialysis or any other types of programs? We partner with people at a reimbursement level. And those are the 5 types of different delivery type models that are out there. If you kind of have to capture all the talk that's swirling around in every hospital in America, and you say, okay, well, what you're really talking about is one of these 5, and that's the way it works. Okay, so let's move on, please, to slide 31. And tell me when you're there.
Yep.
Okay, slide 31, facility impacts. So let's slow down a little bit and talk about this. I'm cognizant of the time here. I want to give you all plenty of time to ask questions and have a little discussion. So care is going to be delivered in non-traditional facilities. So think back to the gray and pink slide with the circles. Those are non-traditional facilities like the CVS's, walk-in clinics, urgent care, home delivery, things of that nature. And the next bullet, and we're going to go through every one of these, greater reliance on developers and property managers. And why is that? Again, I can say this because I spent my career on the provider side, and I know y'all are getting tired of hearing that, and I'm going to make a provocative statement, but hospitals traditionally have not done a phenomenal job managing their own real estate. It's been a struggle. You know, hospitals, we're in the business of delivering care. We're not in the business of managing properties. So hospitals are purchasing physician practices left and right, and so let me just give you an example. So medical office building, professional arts center across the street, where the developer had 8 or 10 tenants. Those tenants are now purchased by the hospital, and so the developer is like, oh, now I have one tenant, and it's the hospital. So the hospital now has leveraging power over those annual lease cost increases and can have a bigger say-so what's going on. So what does that mean to the developer and to the property managers that manage that property? How then do they survive when they've got a single-tenant occupancy? It's very difficult. And the more that developers and property managers, and even for architects and construction managers, to understand where providers are headed in the facility side of the new care delivery models. I know that's a big sentence, but the better you understand where the hospitals are headed, the better you're able to partner with the providers to look for those high-value real estate locations. How can we develop a space in either retail or urgent care or walk-in? How can I lower the operating cost of my medical office buildings? How can I partner with the provider to help them build multi-specialty clinics and ambulatory surgery centers? And here's one that we're going to talk about. I want everybody on this call that's on the design or construction or developer side to start thinking, you know, why can't I own the facility? And for the providers, for forever, we've always said on the provider side, I want to own everything. I want to control my destiny. I don't want somebody coming in my hospital and knocking holes in a firewall at a corridor, a cross-corridor door to run a cable through there. And how do I know that somebody that owns the building besides me is not going to do that? Well, guess what? I can assuredly tell you from my experience right here in Haiti and from all over America, healthcare is not a building. Healthcare is something that's done to a patient, and it can literally be done in the dirt. I've seen it with my own 2 eyes. Facilities are great to have, and they're very important for high-quality care and for comfort of the patients. But the notion that hospitals and providers have to own everything that's in their domain needs to change. And we can reduce and remove costs within our expense side in a big way if we start thinking, wow, why don't we let developers and property managers and construction managers begin to become the ownership role? And what does that look like on the construction manager side? I'm kind of getting ahead here, but on the construction manager side, you know, if you build a building, you can probably maintain it at a less cost per square foot than the expense side of what's being done in facility departments throughout the country. I've seen this with my own 2 eyes, and it can be done. So let's move on to slide number 32. All right, let's talk about scope. Cognizant of the time here, I'm going to need to move a little bit quickly. So when you talk about scope, through health information technologies and through process improvement, the more efficiently we can push patients through their clinical experience, the smaller the footprint of a building. So think about that. Let's use an ER as an example. So take an existing 20-bed ER that's maybe seeing 1,900 patients per year per room, and that's a pretty common figure. Suppose we were able to improve the process via design, via operational improvements, and via better use of health information technologies, and that we were able to push that per room visit number from 16, 17, 1,800 visits per room per year to, say, 2,100, 2,200 visits per room per year. Well, guess what? Now, instead of having to build 10 new rooms, maybe I only have to build 8 new rooms or 6 new rooms. Well, as you all know, an ER room and the associated core spaces and everything else that goes along with it, waiting, corridor, so on and so forth, you're talking real money. And if you expand that concept to every single department of the hospital, guess what? You wind up building a highly efficient, smaller hospital, and so therefore the debt service cost to own that building and to operate that building is less, and you get to recoup that cost savings year in and year out over and over. So y'all can read that slide. So let's move on to slide 33. All right, so let's look at this. From the top of this, Sergio, are you there on slide 33?
I'm moving along with you.
Okay, great, very good. So when you look at the different types of facilities, obviously the highest cost is elite central facilities that we've all been working in, our typical acute care hospital. And as you move down the value chain of hospitals, you get down to home care that has zero facility cost. Clearly, if I'm in a capitated environment and I'm the CEO of my hospital, I want to be treating my patients in facilities that are at the lower end of this. Clearly, right? That's what I want to do. Here's a thought for you. It's being discussed right now that acute care hospitals in the not-too-distant future are going to have much larger ICU units and fewer medical beds. Why can't a patient be treated at home medically and reduce length of stay, presently what's being seen? As the baby boomer generation begins to really affect our society, as you know, I don't need to quote all these figures to you, 10,000 a day are turning 65, and in 2030 is the peak year for people 65 and older, and you all know that in the last 5 or 8 years of your life, you'll spend 80% of your lifetime healthcare expenses. So hospitals are going to need to respond to that, and it's going to be the people that are going to be in our hospitals are going to be extremely sick, very acute, likely ICU patients. So think of this is just for directional purposes for your thought. Think of acute care hospitals as becoming giant ICUs and surgical facilities. So let's move on again to slide number 34. And I want to revisit this again. So the scope of your projects to become more efficiently moves down to the right into the pink areas. We need to figure out how to do that. Design and construction departments need to be thinking about how they can be part of the business model and not just putting up bricks and mortar, but actually thinking in ways to become more operationally efficient, better use of health information technologies, and doing construction in lower cost types of facilities. All right, so let's move on to slide 35, please.
And this is where we're hitting up that story that was recently published. It's the cover story on health facilities management that you and I were talking about earlier, Tom, which, by the way, everybody that's on this webinar today, please feel free to email me or comment right now, and if you want a copy of this publication, we'll get you guys a PDF copy of it. And it's interesting, Tom, because there's some great stats in here. We won't be able to get to them because there's a lot of information, as you mentioned, but there's some great stats into how one of the key takeaways that I got from here was how a lot of these health systems are moving away from these mega projects and focusing more of their investment dollars, at least in the near future, in some of the smaller renovations and smaller type projects. And I think that's kind of resonating with a lot of the information that you've been providing to this point.
Right, I'd agree. And if you take a look at slide 36, clearly I think everybody on, yeah, go ahead.
Yeah, no, this was a quote taken directly from this article where Steve Higgs with KLMK Group, which is a healthcare consultancy that does a diverse range of services in the healthcare side, it's talking about what they're referring to this perhaps as a pause because of this demand that they're referring to. And again, going back to people maybe just sitting around waiting for what the effects of healthcare reform or Obamacare or whatever you want to call it, as you said, what is going to be the true impact of that into the planning, design, and construction of new facilities.
Right, that's exactly right, Sergio. And the thought and the discussion around the industry is this: on one side of the fence, some folks are saying, well, because of technology advancements like health information technologies and better care, we're not going to need so many patient beds. And then on the other side of the fence, the other argument is, yeah, but the baby boomers are getting older and they're going to be sicker, and therefore we're going to need more beds. And yet, over all of that is a cloud of uncertainty of what actually is going to be the reimbursement come next year. So I challenge you to think this. So you're considering adding on a $50, $100, $200, $300 million expansion or a new greenfield hospital. Well, as businessmen, I think all of us would be nervous to accept that debt service, not knowing what our revenue picture is going to look like only a year from now. You clearly don't want to get into a situation where reimbursement is below what your revenue stream is on a revenue-producing project in your facilities. You're never able to climb out of the hole. I can assure you, having traveled around this country most of my career, many hospitals are in the red. They're barely breaking even. A lot of them are doing well, but the vast majority are struggling every day, fighting for every penny. And so clearly, I think every one of y'all would agree that the amount of large projects is definitely reduced in a substantial way, and we're seeing lots of smaller renovation facility type projects. What can we do with what we have, and how can we do it for less? All right, and so let's move on to slide 37. I think we just talked about that, but it's worthy to look at. It's a very powerful quote.
So just while we're moving on for the discussion, I guess I'd ask our audience to maybe chime in and, whether or not they agree with this statement over here by Dan Cates with McCarthy Building Companies as far as larger projects being, fewer and farther between. So we'll see what everybody says in response to that, Tom, and I'll move on to the next slide, which is design and construction response.
Right. So you can see right there, architects. It's not enough that architects are designing facilities. They've got to become designers of operational solutions. You got to be part of the team. And let me just share a poignant story with you to kind of put that in perspective. I was hosting a panel last fall. There was a couple architects and a couple of hospital CEOs on the panel. We were discussing a variety of objects. And one of the CEOs and one of the architects had known each other on a project before and got into a pretty good discussion. And the CEO, she takes her glasses off and she looks at the architect and says, "Ed, let me tell you something. I don't really care what your fees are because it's an insignificant portion of the total project cost. But what keeps me up at night is not having the solutions to what I'm doing in my hospital. And you need to provide solutions for me. And if you can bring solutions to my hospital, and I'm happy to pay you whatever your fees are." And I had to take a pause, and that was profound. When you think about it, you're paying an architect whatever it is, 5, 6, 8%, of a fee. When you look at that fee across the project cost, it reduces dramatically. And so the architect's fee is never going to be a make-or-break decision whether you're going to move forward on a revenue-producing project. But what does make one architect stand out from the other is when an architect can deliver an operational solution and has the built environment to back it up. Now, that's real differentiator right there. So let's move on to construction managers. Shift towards ownership. We mentioned that a few minutes ago. Start thinking about, you know what, why don't I just build the facility for the hospital and do some kind of a lease, a public-private partnership, whether it's P3 or P2, doesn't have to be a public entity involved, it can be private, and facilities management. I can assure you most construction managers on this call would say, if I knew that I was going to own that building, I would design it slightly differently, perhaps, but I sure as heck would put in different mechanical, electrical, plumbing, and fire protection systems that are going to have a better life cycle and lower life cycle cost, and therefore could spend less over the next 30 or 40 years of the building. I guarantee you that would happen. And for developers, you're going to have to start thinking retail and in different environments and helping the hospitals move out to provide the care in the neighborhoods where their markets exist. It's not just medical office buildings on the campus or down the street from the campus anymore. That's still going to continue to happen, but there will be single-tenant facilities. Developers need to think large multi-specialty with surgical centers. They need to get very skilled at building surgery centers and doing more work. I see construction managers and developers becoming closer together in their skill sets. And with that, we can move to slide 39 and answer any questions or discussion.
So Tom, thank you very much. And again, I'd like to encourage everyone to start submitting your questions using the chat feature. While those questions are coming in, Tom, I wanted to ask you from your perspective, I heard a lot of presentations over the weekend, as I mentioned, at this conference in San Francisco. And I got the sense that the discussions around the cost controls that are being, I guess, precipitated by this healthcare reform, a lot of them were around cost controls and cost reduction as it related to improved operations efficiency. So mostly on the operations side. But I heard very little talk as it related to, the design and construction phases of the project. And as you and I both know, I think there's a lot of room for improvement. Is it an issue of, the C-level executives not looking into that area as an opportunity perhaps to reduce costs and maybe take some of those cost savings and reinvest that, money, whether it's new technologies, new facilities? What are your thoughts on that?
Sure. Let me give an example. Still today, and it has been for many years, and I go back to an example of an ER. It's a department that most everybody's probably either been in, and there's certainly been many of them built, and so everybody can pretty well understand. So typically what goes on, patients start lining up in corridors, and they start putting patient signs on the wall, down the corridors, in the hallways when they're at peak capacity and beyond. And eventually the hospital figures out that they need to add capacity, and they pick up the phone, call an architect. I know there's lots of steps in between, but just go with me. So they call the architect and they say, hey, we need a new ER. And the architect says, okay, well, how many exam bays do you need? And they say, well, we're presently got 20 rooms, and we're seeing, some number per visits per room per year, and we're anticipating an additional 30,000 visits over the next 5 years or 10 years. And so what happens, unfortunately, is just a little mathematical. Oh, you're seeing this many patients per year per room. You're anticipating X more. We'll just divide that number, and that's how many more rooms you got to have. Well, what did you get? What did you get? You got a bigger box. You didn't get a better box. And the better solution is to redesign the process before you design the building, and you wind up getting a smaller, more efficient building that not only costs less on the capital side, but costs less to maintain and operate over the next 30 or 40 years. That's what we're seeing around the country. Those are the recommendations we're making to owners beginning to think about major capital expansions. Let's improve the process. And then secondly, what's the single biggest thing that causes log jams in ERs? It's downstream services and available med-surg beds, ICU, and OR capacity. And whenever you expand an ER, you need to immediately be looking at your available capacity and the downstream services to prevent log jams. In fact, just to get on my soapbox, I get called into ERs so often to look at log jams, and guess what I find? It's not a capacity problem. It's downstream services that can be fixed operationally to a point.
Interesting. Now we have a comment here. Somebody says, my experience, and this is a healthcare owner, is that we design and build facilities that are not operated in the vision that they were designed, which leads to waste.
Yes, exactly. There's a lot of reasons that that causes that, and let me give you one. So by the time you've had some user group meetings and you go through CDs and DDs and you got the construction, and in California it takes you a year or more to get a permit. Same in Florida, it can be. By the time you actually get the building built, the user groups that you originally designed it in have moved on. And so somebody else comes in and says, oh, this is completely wrong. We can't operate like this. And so right off the bat, that particular unit or department or facility never gets driven the way it was designed to be driven. And that's what happens. And unfortunately, in fact, we see this with replacement hospitals, even directly across the street. You build a brand new hospital, the staff moves in, and guess what happens? They want to operate this brand new Maserati hospital like they were operating their older hospital, and they take all those old habits into the new hospital, and the most they ever get out of their new high-speed hospital is second or third gear. And that's waste. That's trillions of dollars a year in waste across our entire industry. It's a very big deal, yes. And in fact, let me get back on my soapbox. Hang on, Sergio. I get all wound up on this. Gosh, just lost my train of thought there for a second.
Well, let me ask the question
Yeah.
that came through, because they followed that up by asking, how do you see adding metrics to monitor and adjust operations to design parameters and business needs?
Yeah, great question. That could be on a cost base per square foot of a department. So let's say, example, you've got, just take some easy numbers, 20,000 square foot ER today, and the operational cost of that is X. You move into your new ER, and you can measure your operational cost shortly after, you got to give it a few months to get settled in, but you can measure metrics on operational cost right off the bat. You know what those numbers are. That's readily available, what that cost per square foot is. You can measure it at a department level. You can measure it at throughput. In fact, let's talk about ERs again. It's pretty easy within the data when the patient presents at check-in or triage. When the patient hits the door, there's plenty of metrics, and it's door-to-door, door-to-floor, door-to-disposition. All of these times can be measured, and if those times are not shrinking in the new facility, then clearly you're seeing waste. I can surely tell you this. If those metrics between the old ER and the new ER remain the same, there's waste. And we've got to always be reducing waste constantly. Yeah, I agree with that 100%. Those are ways that it can be measured. And it takes resources to do that measurement. And, of course, resources cost money, but the cost of the resource, whether that's 2 people, a consultant, or 10 people, or a whole department, is a fraction of the cost that you're going to save in expense reductions. I absolutely am on board with that. In fact, if those kinds of studies can take place before an architect's engaged, you've got more data to be able to input to the architect to design an architecturally built environment. In fact, this is what I want to mention. I know we're about out of time, but my last provocative statement is this. Our operational delivery models are the result of the architectural built environment over the last 20 or 30 years. You say, well, Tom, what do you mean by that? Clearly, every hospital in America has been added onto and added onto and added onto, left, right, front, back, top, every which way you can imagine, and countless renovations. And so the way that patients are processed through that menagerie of renovations and additions and changes in elevations and departments moving here and there and all over the place, what do you think the operational efficiency is in some of those hospitals? It's horrible. And so those habits by the staff, when they move into a brand new facility, they bring those bad habits with them. It's not their fault. It's just the way that it's been for decades. And they take these habits into the new facility, and what you think your expenses were going to be in the new hospital when the CFO and the team put together the pro forma before the project was ever approved, guess what? Expenses are through the roof, and people start screaming, and it's like, what's going on? And it has to do with human behavior from the old to the new, and it can be solved simply by a large investment in education and how we're going to operate the new facility. So that's my soapbox.
So how do you see some of these initiatives, I guess, or I guess a push for cost reductions and efficiency and eliminating waste as being pushed down to the planning, design, and construction group?
Well, exactly that, just what we mentioned. If you can improve the process in any particular department or a set of departments such that your numbers of patients per day, per week, per year, whichever department or whatever the metric is, if you can improve the operational process, what goes on internally from the time the patient walks in the door to the time the patient leaves, can they be cared for in a high-quality manner with fewer steps in a shorter amount of time? And in so doing, therefore, you need less bricks and mortar to be able to do it. Let me say it another way. Let's say that in a particular examination bay of an ER, I'm seeing, let's just use round numbers, 1,500 patients per year. If I can improve that process so that that one room can see 100 more patients a year, okay, guess what? times however many number of rooms there are in the ER, I have just kicked the can down the street X months or years before I have to spend more capital dollars to improve the process. Excuse me, before I have to spend capital dollars to build a new facility. In fact, I spend a lot of my time helping hospitals improve their operational efficiency now so they're earning more revenue immediately while we're in the design and construction process. So it takes X years to scope, design, permit, build, and move in a new facility. Well, if I can improve the process today, and generally it's very little money, then the hospital gets to realize X incremental revenue immediately today before the new facility opens 2 years from now. That's real money.
All right, so we have another good question here. Somebody says, I am a big supporter of the Peter Diamandis model of decentralizing, dematerializing healthcare. Have you seen any providers embrace the home care model by building new departments to negotiate this transition?
Can you read that again for me? I can't see it written down, so just go a little slower.
So the question here is, have you seen any providers embrace the home care model by building new departments to negotiate this transition, and the transition meaning to decentralizing and dematerializing healthcare?
Yes, in fact, that's happening all over the country right now, not just in home care, but I refer you back to the slide of the pink circles, the wellness subsets. Many of our clients around the country, if not most, are in some element of that graphic right now, whether it's home care, urgent care, retail, walk-in, this or that. That is absolutely happening. In fact, hospitals call me in and say, will you help us scope out a new hospital wing? My first question is, why don't we figure out a way to provide care for fewer patients in the hospital, and let's deliver that care in a lower cost environment and delay that $100 or $200 million expense. Absolutely. That is happening all over the country. That graphic is not anything proprietary. That's just a graphical representation of what's happening. And, of course, in every market in America is different. There's no one size fits all. But graphically, from a high level, that's what happens. And each provider within their own market needs to figure out what works best given their demographic. Now, what exactly does that mean? You need to think in terms of population health management. Every community is going to have X numbers of new people coming onto the rolls, and we need to get better at treating large numbers of people with the same acuities and comorbidities, like, for example, the obesity example we used early on in the presentation. If I knew that a very large percentage of my primary care had obesity issues, I would absolutely be the king of treating obesity, no question, hands down. Same thing with large pediatrics, large elderly, large youthful populations, so on and so forth. I would figure out where my largest demographic is, top 2 or 3, and I'd become the very best at that, absolutely. And that's population health management, and then therefore I would target my facilities in those areas where those types of people live with those care providers and physicians, absolutely. I want my patients kept well closer to their home. When they come to my hospital, I have to spend a lot of money to care for them and get them well.
So and I'm going to make one more call for questions, because obviously we've gone over time a little bit, but one question that I had was, are program managers, let's say some of the larger construction firms out there, in a position to now maybe develop new areas of expertise that will address a lot of the questions and issues and even the suggestions that you've been making now? You think
was
you
it
see any of them
program managers? Yeah. Was it program managers or construction managers?
Well, I guess the program managers, more the owner-rep type associations.
Yeah, absolutely. I see program managers operating basically in 2 models. There's supplementing existing design and construction department resources. That's one type of program manager. The other type of program manager comes in and is part of the operational solution and is on the team very early on to help properly scope the project from an operational perspective. I think most design and construction projects, the way they typically go, the projects get scoped, they get scoped, and in an effort to please so many different stakeholders, the scope continues to increase, and eventually somebody says, hey, let's put a budget on it. We put a budget on it, and guess what? We've blown the preconceived idea of what the budget was before we ever got to DDs, and that's a huge problem. You know, you got to be able to manage the scope definition before you get to the point where we're already in an over budget situation. And how do you do that? You got to do that by people that are knowledgeable in healthcare operations at the fine-grained level, and be able to translate that back to the design team and say, hold on, the available money that this project can support on a revenue-producing side is X, and you can work it in to a scope that fits that program. And unfortunately, in an effort to please every single stakeholder, projects get out of control in a hurry, and I'll bet you every single person on this call has had that experience. You've got to be able to manage the stakeholders and stay within the confinement. That was one of the early lessons I learned in my career on the for-profit side. We never wanted to have a project that wasn't revenue producing. You absolutely have to maintain within the box and in the capital requirements. Nope, I can assure you this, nobody's happy when a revenue producing project does not produce revenue because it was overbuilt. The key is to not overbuild and not underbuilt. You got to right size the building, and it takes that's the art of design and construction, not the science. That's where I see program managers needing to head to provide value. It's not just check and pay applications and job site inspections and attending gazillions of meetings.
All right, Tom. Now, I know that you've got to get back to your project, so I'd like to end our presentation at this point. If anybody had any questions that maybe went unanswered, please feel free to email me with those. Tom, are you okay with us sharing this presentation in a PDF format?
Yeah, sure, absolutely.
So again, thank you very much, and I would love to hear more about how this new hospital in Haiti is coming along. You know, maybe you can even share some pictures with us. I mean, I think it's a great endeavor that you've engaged in. So we hope. When are you back in the mainland here?
Well, you know, getting out of Haiti is always a little bit of an adventure. So the flight's scheduled for tomorrow night. So if I'm home sometime Saturday, I'll be happy. So.
Glad to hear that. So have safe travels. And again, thank you so much for sharing some of this information. And we hope you'll come back and maybe do another webinar for us in Q2.
Great. Thank you all very much.
Take care.
Bye-bye.